Hi, everyone. Welcome to LDI's seminar on financing long-term care. I am Rachel Warner. I am LDI's executive director. Thanks everyone for being here today. We had a big interest in this topic with over 700 people registering, and many of you submitted questions in advance, so thank you for doing that. So, as a way of introducing long-term care, at some point, most Americans face the challenge of trying to find help with their daily activities like eating, bathing, and mobility, either for a family member or for themselves. It's often a challenge with no easy solution because the US has no comprehensive system to pay for long-term care or long-term services and supports. And yet the need for long-term care is large in this country and it's growing. 70% of older adults will need help with long-term care at some point, and nearly half of them will receive some form of paid care. A 65-year-old will incur an average of over $120,000 in paid care expenses over their lifetime on average. And about 15% of older adults spend more than $250,000 on long-term care, with families today paying for about a third of that care themselves. The costs of long-term care are large and can disrupt even the most well-planned retirement, and families often have to step in as unpaid caregivers to fill that gap. The burden of unpaid care is substantial, bringing emotional, physical, and financial strain. It reduces retirement savings and it creates difficult trade-offs between work and caregiving responsibilities. Potential solutions for the long-term care crisis in this country have been debated for many years, and they range from expanding current public programs like Medicaid to stabilizing the private market for long-term care insurance, or a combination of these approaches. But past policy chapters highlight just how challenging and costly it is to address the gap in coverage and financing for long-term care. So today's conversation, we will examine how we can apply lessons from the past, leverage the numerous policy ideas that have been proposed, and be mindful of the current political landscape to develop a sustainable system for caring for aging Americans. We're lucky to be joined by three of the nation's best experts in this area. Richard Frank is a senior fellow in economic studies and director of the Center on Health Policy at the Brookings Institution. He previously served as the assistant secretary for planning and evaluation in the U.S. Department of Health and Human Services. Narda Pakchi is the vice president of policy and programs at the SCAN Foundation. She previously served as the Medicare and Medicaid policy director for the U.S. Senate Aging Committee under Chairman Bob Casey of Pennsylvania. And Tamara Konecka is the Lewis Block Professor of Public Health Sciences and a Professor of Medicine at the University of Chicago and is a national expert on nursing homes and long-term care. So thank you all for joining us today. Tamara, I want to start with you and ask if you could provide a basic overview of the current landscape of long-term care in the United States, including how it's a complicated landscape, how people can get coverage, who's covered, what the gaps are.
Certainly. And I'll start by saying thank you to Rachel and colleagues for putting this panel together on this longstanding and important challenge. As Rachel noted, we don't have a comprehensive or in any way a rationally planned system for long-term care financing in the US. It's a patchwork of funding sources, much of which evolved by historical accident, and a patchwork that leaves a lot of gaps. So first of all, Medicare. Most older adults rely on Medicare for much of their healthcare in other parts of the healthcare system, but Medicare does not directly cover long-term care. It covers rehabilitation after an acute event for a limited period of time, sometimes in the same settings where long-term care is provided, like in the home or in a nursing home. There is a private market for long-term care insurance, which we'll talk more about later. But a relatively small proportion of seniors have these policies, something like 10% of older adults. And so long-term care insurance ends up covering an almost trivial percent of current long-term care spending. There are some other more local sources like areas on aging, but these local sources also end up being a very small piece of the pie. So other than private spending, that really leaves Medicaid, which is by far the most important public payer in the long-term care space. covering more than half of what is spent on long-term care or long-term services and supports in this country. On average, states spend about a third of their Medicaid budgets on long-term care, which is really an extraordinary number when we think about all of the other components of Medicaid programs like healthcare for kids and the ACA expansions. About two-thirds of people in nursing homes at any point in time have their stays paid by Medicaid. And these aren't people who were necessarily low income or on Medicaid prior to needing long-term care. It's just that long-term care is really expensive. So they started out probably with some income and assets, but then paid for long-term care privately until they spent down or depleted these resources. In most states, a person can have at most $2,000 in assets, as well as have health needs in order to qualify for Medicaid long-term care. Nursing home care is an entitlement under Medicaid state plans, meaning that if beneficiaries meet eligibility criteria, both financial and health, then their care must be covered by that state Medicaid program. All states also cover some degree of home and community-based services, or HCBS, as an alternative to nursing home care, sometimes through state plan amendments and sometimes through waivers to the law that established Medicaid. If they do it through waivers, states can limit spending through caps on the number of slots or caps on spending or geographic limitations. And although on average across the nation, the spending on HCBS has increased dramatically over the past few decades, increasing access to that kind of care. In fact, it recently surpassed spending on nursing home care, but still states vary widely in what they cover. One might think of this as states tailoring their offerings to the needs of their populations, but it also raises the issue of inequities. Not all older adults can get the services they need if they live in the wrong state, even if they qualify for Medicaid. So overall, Medicaid's by far the dominant player in long-term care financing, but with strict means testing and few options for those who do not yet qualify for Medicaid. What this patchwork of financing means is that there are large gaps in coverage and access, especially for the middle class. People who aren't rich enough to self-insure or just not worry about these costs, but also not poor enough to qualify for Medicaid yet. So there's a lot of research and policy attention to Medicaid, but the real gaps in the patchwork are probably for the middle class. Where families often struggle to piece together sufficient hours of privately paid long-term care combined with sort of the unpaid family care just to muddle through. Which brings me to the final implication of this patchwork that I want to mention that Rachel also brought up in her introduction, and that is our strong reliance on informal or family care, which is generally unpaid. About 3/4 of older adults who need long-term care get some kind of family care, and around half get only family care. A large body of research has established that caregiving comes with its own direct and indirect costs to caregivers and to society in the form of lost productivity and wages. It's always been the norm that there's a lot of family care, but as our population continues to age and our population pyramid continues to invert, it's not clear this will be optimal or even sustainable into the future.
Great, thank you for that great introduction. It highlights the many challenges and the gaps that are in our current long-term care system. And Richard, I want to turn to you and ask about one of the commonly proposed ways to fill that gap, which is through a private market for long-term care insurance. And so it often seems like a sensible solution, particularly in the US, where our healthcare system relies heavily on a private market to cover healthcare costs. My question to you is this a realistic solution and why?
Yeah, well, thanks, Rachel, and thanks for having me today. As Tamara mentioned, somewhere between 7 and 10% of older adults hold private long-term care insurance. So that's hardly a success in the marketplace. But we Americans, we love the freedom of the market and the private market. And so by definition, the private market means that coverage is voluntary. People decide whether they want coverage and they go out and seek an insurer and buy insurance if it suits them. Um, it also means that when they decide, they come into that transaction knowing more about themselves than the insurer. And what that means is they know more about their health status, they know more about their family history, whether their parents or grandparents had dementia, for example. And so that gives them an advantage in buying the insurance. And it also means that the people who are most likely to avail themselves of that coverage or likely to need long-term services and supports are the ones who are most likely to buy the insurance. And what that does is it creates a distortion in the insurance pool. So what happens is that insurers plan to cover the average person, and if they don't get an average draw of the population because of this information asymmetry, what happens is they are prone to lose money or have to continuously raise their premiums to catch up. And so that distortion in the insurance pool is what actuaries and economists call adverse selection. And insurers understand this problem. And what they do is they take action to try to limit the consequences of that problem. And in the long-term care insurance market, what they do is they do things like underwrite policies. And what that means is typically a nurse or a social worker will be sent to somebody's home, for example. They will take a family and medical history. They will do a basic examination to judge whether this person is likely to be a high risk of needing services. And it turns out when they do that, the industry reports that about 30% of the people who apply for the policies don't qualify because they're underwritten out. Academic research, which is a little less optimistic, finds that it's about 40% of people are disqualified from buying a policy. And then there's, I guess it's urban folklore at the very least, that many people who, for example, approach a broker for advice on what to do about buying long-term care insurance are often informally screened by the broker and very often discouraged from even applying if it looks like they're going to be at risk. So that 40% is likely to be even higher. And so that sort of starts to illustrate why, in fact, the market perhaps hasn't prospered as much as many of our other markets do.
And so just a follow-up question. So 30 to 40% at a minimum are disqualified because they have pre-existing conditions or something else like that, which puts them at high risk for having to use the insurance. When I'm trying to remember when it was, a couple decades ago, there was a lot of hope that long-term care insurance was going to be the solution, and there was some growth in the market initially. Can you just talk us through what happened? I mean, it failed in part because of the adverse selection that you're talking about, but what was the disconnect there?
Well, I mean, there are many things that go wrong in a long-term care insurance market compared to a traditional market for widgets. And one of them is the adverse selection, but there's also myopia. Many of us just don't believe this is going to happen to us. It happens to people in our neighborhood, it happens to people all around us. But in fact, if we feel healthy, We don't believe it's going to happen. And if it does happen, that's a long way away and we'll deal with it then. And that tends to dampen the demand for the service. Uh, and then there's been a lot of, because the risks are very hard to predict and they happen a long time out. So you buy a policy when you're 50, you probably won't need to use it till you're around 80. And so a lot can happen in that time. There's inflation, there's all sorts of other things that happen. And all of those things make running a policy much more difficult. And insurers face sort of what they call the tail of the distribution that they're very worried about. And that has caused a lot of instability in the market. And so lots of insurers went out of business. Many of them were in situations where they couldn't pay claims. There was inflation during a period, and many people didn't buy inflation protection in their policies. And so their policies weren't very worth very much when it came, and that causes people to lose confidence. And so all of those things combined have sort of really dampened the demand. And even in circumstances where there's a lot of encouragement to buy things, like the Federal Employees Health Benefit Program or the California Employees CalPERS, in both cases, they had very generous and very supportive environments for long-term care insurance and were very gentle in their underwriting. And they've had a tremendously difficult time sustaining their policies, and the enrollment has shrunk over time.
Yeah. And just one more follow-up question, and Tamara and Narda, if you want to jump in, feel free. So you've described a number of ways in which this is a very challenging market, and although long-term care insurance seems maybe from on first pass like it should be a solution, it's hasn't been to date. Are there any ways to change the way we're thinking about long-term care insurance policies, regulations that would improve the market and make it more sustainable or increase the uptake to make it a more realistic answer?
Yeah. I mean, in a sense, we should think about this in two ways. One is how you get into the market, and then how the market functions once people are in. And I think that there's certainly a feasible approach to having private insurers operate the actual coverage. And I don't think that's necessarily a problem. The problem is defining how people get in. The whole adverse selection problem comes from it's voluntary. So if you make it mandatory, that means that the risk pool, by definition, winds up being the same as the population. And that changes the ball game. And so if you do things like regulate the market, force some consistency and benefit, make everybody join, then private companies can do a fine job potentially delivering the actual coverage. And I think that's the issue. And in fact, in some of the initiatives that are underway currently in some of the states, you see that kind of page taken out of the playbook.
Okay. We're going to get back to state level things. Just Narda. Oh, both
Oh,
Tamara and Narda want to jump in.
well, it actually does go into state a little
Go
bit,
ahead.
but I do think one of the promising things that we have seen with the Washington, for example, and the WaCares initiative is with that their mandatory long-term care insurance program that the government is able to sort of de-risk a little bit for the private insurance market. It's still mandatory. Folks are, required to participate, and there's a payroll tax associated with it. But as a result of that, some of the supplemental private long-term care insurance options can become more affordable and more attractive to residents there.
To me, the key is the affordability piece. I mean, I think there are multiple ways to get there. It could be making it mandatory and solving some of the adverse selection problems. It could be some kind of public-private partnership where insurance rates are subsidized for individuals. But the bottom line is long-term care is really expensive. The median income for Medicare beneficiaries right now is $36,000 a year. And, when you're looking at paying more than $100,000 a year for, nursing home care if you need it, and, home care costs can also add up to similar numbers if you need enough of it. The idea of either saving enough for that or, paying $3,000 to $5,000 a year for a long-term care insurance policy when you'd rather uh, deal with other priorities in your life, like maybe, saving money for other retirement needs. Maybe you're still getting kids through college. Maybe you're just struggling to pay bills. It's just really expensive. Long-term care is expensive, and those policies are expensive. And so I think the bottom line has to be make the policies affordable so that people can actually sign up, given their other priorities.
Yeah.
Great.
Well, as you say, though, it's expensive, and sometimes we don't need the full loaf, right? Sometimes we can just help people a bunch and not help them completely, and that's one way to do it. But then you get into the tension of how much is enough, and then what happens to the people who are the most needy. Do you leave them sort of in the lurch? And I think that's what makes this so hard.
Yeah. Okay. Well, shifting gears a little bit, I want to talk about some of the legislative approaches that have been floated in the past. So, Congress and other stakeholders have periodically and regularly weighed in on ways to improve long-term care in the United States. So, there's been a lot of potential policy proposals, and Narda, your group at the SCAN Foundation recently released a detailed compendium of all the various proposals over the past uh, recent years, including many that are active today. So I was wondering, maybe in broad strokes, if you could tell us what some of those are, along with some top lines or pros and cons. It's not exhaustive. It's an exhaustive list. You don't have to do an exhaustive job today.
I hear you. Thanks so much, Rachel. And I'm also incredibly excited to be here today. And just I think the paper that you all recently published and the compendium that the Scan Foundation worked on in collaboration with the LTS Center at UMass Boston with Mark Cohen and team and ATI really demonstrates that there have been a number of committed people working on this issue for decades, 50 years in the case of the work that you all did, and the compendium that we recently put together includes legislative proposals over the last 30 years. So there's been already a lot of work in the space, but what we find is that people continuously every year or two or every new Congress, et cetera, the question comes up again of, okay, we want to revisit the long-term care discourse. Where do we start? Have you thought about this? Have you thought about that? And the answer is generally yes. It has been thought of. It has been analyzed. There's likely a legislative proposal for it or a reason why there isn't. And so this compendium really intends to be a starting point for some of that dialogue so that people on the Hill and the policy stakeholder community can evaluate some of those different approaches based on what the political climate is sort of willing to allow. And so it includes approaches with respect to Medicaid reform, which obviously in terms of the benefits of that, it's building on an existing infrastructure, which might be a little bit more administratively feasible in many ways. As Tamara mentioned, it's obviously, though, very limited in its scope and who it covers. And the means tested element of it means that it only reaches a designated portion of people. There are also proposals in the Medicare expansion space. I know Richard and his team have done a lot of work in this area, which obviously creates a broader coverage system and potentially enables more seamless transition between healthcare and long-term care. But it's, there is a cost element to consider there, and can be quite politically complex. Obviously, we've also thought about a number of new social insurance programs, a dedicated universal solution, that obviously addresses a lot of potential equity concerns and issues. But, I think folks in this space, it can sometimes be hard to agree on how that should be designed, how exactly it should be paid for, and how it should be administered. So, in terms of that complexity of coming to consensus on a lot of those necessary decisions, it can be incredibly important. I think Richard already spoke very beautifully about the private insurance market, so we know some of the pros and cons there. But those are the sort of general policy chassis that the compendium really seeks to provide some more detail about those legislative efforts. I did want to just end with one quote that I will. Mark Cohen always says this when we work with him. It's a quote from economist Milton Friedman that only a crisis, actual or perceived, produces real change. When that crisis occurs, the actions that are taken depend on the ideas that are lying around. That, I believe, is our basic function, to develop alternatives to existing policies, to keep them alive and available until the politically impossible becomes politically inevitable. And so, with just the environment that we're in right now, increasing, attention on this issue from the public, people are really feeling the squeeze. My hope is that there will be some sort of political window that opens, and that hopefully this compendium, we don't have to start from scratch. We can start the conversation a little bit further along.
Thanks. And thanks for putting out the compendium. It's a really useful resource. Related to the sort of political will to do this, it's often, I think that there's no disagreement that there's a crisis, I think. Uh, but finding a solution for which there is political will is often seen as the major barrier, that we just don't have the political will because maybe it's expensive, as Tamara has pointed out. So I just wondered if you could talk really quickly about how we might think about and this was a question that came in from the audience, how we might think about creating the will to sustain an effective movement like you talked about.
Yeah, I think, one of the both benefits and challenges that we have in this space is that there are so many different advocacy stakeholders and interests that are focused on this issue because it really touches so many dynamics. It touches aging, it touches disability, it touches labor. And those three, factions have historically had a hard time being aligned in terms of being able to move forward with a unified ask and a unified message. And so it becomes pretty easy for a potential legislative champion to want to turn that away and not have to deal with the messiness. So one of the things that I think is really important is building that coalition across aging, disability, labor, and potentially others, right? Because this is, as Tamara said, an affordability issue, and that seems to be, for example, something that's really resonating right now in terms of public messaging. So to the extent there can be a unified and expanded coalition that is generating demand and urgency with a unified ask, I think that's really going to be important in terms of anything meaningfully moving forward.
Great. I have Richard tomorrow. You want to add anything?
Uh,
I,
uh,
nothing.
I'll only say that, I think right now this feels like not a moment to get anything done. I think Narda is exactly right, that our job is to kind of set things up so that the evidence is there when decisions can be made. Um, but I guess I always look back with some hope to the passage of Medicare Part D in 2003. To me, it's an example of, drugs weren't sort of high on the priority list when Medicare was passed in 1965. It became more and more important as we spent more and more on them. And in 2003, whatever you think of Part D and that legislation, the good and the bad, Congress did manage to sort of address that problem and pass, a major change to Medicare. And so, even though this is not a moment where we think something like that will happen, I think that we have to keep in mind that things might change. And hopefully at some point, uh, this problem will be taken seriously again and actually addressed.
Um, just taking off on Narda's missive, Victor Fuchs used to say that big policy changes happen when there's a war, an economic crisis, or both. And the problem with long-term care and long-term services support is that if we wait for that, it may be too late uh, because you need to do a lot of setup. And that's something I worry about. And, uh, to some extent, uh, being too passive here is probably a mistake.
Agreed. Um, okay, thanks for that conversation. I want to, Tamara, ask a little bit more about the role of Medicare, which has come up a couple times already. Medicare, as you know, does not formally pay for long-term care, or historically has not. But there's a common public misperception that it does. And people are often surprised when they find out that it doesn't. So my question is, what is Medicare's role in the current system for long-term care? That is, how do people use it? And then the follow-up question is, what kinds of policy changes there have been some policy changes recently that have aimed to create a more comprehensive role for Medicare and long-term care. Maybe thinking a little bit about the role of Medicare in that way.
Right. Yeah, this is a topic that I find sort of really sort of exciting and promising in terms of thinking about potential solutions. And I should first say that even though I'm a current MedPAC commissioner, the views I'm expressing about Medicare policy here are solely my own and do not necessarily reflect MedPAC thought. Um, so, as you just said, and we talked about earlier, by statute, Medicare doesn't cover long-term care. So it's not like there's been like actual recent policy changes to point to, because Congress would have to, authorize such an expansion. But I think we can really start to see the potential for a Medicare role here when we look at the Medicare home care benefit. So homebound Medicare beneficiaries can use home health when recovering from an acute event after a hospital discharge, but they can also use it directly from the community when a physician signs off on their need, a temporary need for skilled care or therapy. But when we look at the data, the people who are using this sort of community-initiated home health benefit look a lot like long-term care populations. They tend to be older and more likely than other beneficiaries to have cognitive impairment and multiple comorbidities. They can even use, as long as they have a demonstrated need for skilled care, they can even use a home care aid as long as it's coupled with that skilled care. And this use of this community-initiated home health and those home health aids is growing, perhaps as an imperfect substitute for long-term care. So I see this as a really promising place to start in addressing unmet long-term care needs about older adults, because they're kind of doing that anyway, perhaps in a not very efficient way. So, perhaps this benefit could be expanded to sort of relax the strict need for skilled care and to address some of those unmet needs, and therefore kind of start some baby steps toward modernizing Medicare. This idea, it's something that I'm excited about, but, I'm certainly not the only one. This idea seems to be increasing in popularity. Richard, along with Sherry Gleed, wrote a Brookings paper on a similar idea. This has come out as sort of proposals in the last presidential campaign. So they differ in some of the details, but they're fairly consistent in concept. And it seems to me a sort of practical and limited expansion of Medicare, at least as a testing ground toward sort of moving toward moving toward a modernization of Medicare to address some of these unmet needs.
Yeah, and I might just add that, um, or maybe ask a question, which is traditional Medicare by statute can't provide long-term care, but Medicare Advantage, which is now more than half of Medicare enrollees, does, or in some cases is expanding into that area. And we know relatively little about the use of that, but go ahead.
Yeah, no, thank you for raising that. I should have mentioned that. Certainly under MA, they have a lot of Medicare Advantage. They have a lot more flexibility to use their rebate dollars built into the payment system in order to provide some services that traditional Medicare doesn't. And one of these has been sort of home care aides and some kinds of long-term care services. Um, Unfortunately, we don't have a lot of data, just like we don't have a lot of data on other extra benefits that MA plans offer. So we really don't know um, how much take up there is of these services. We certainly don't know the effects of them on patient and beneficiary health. Um, and not all MA plans offer this. It just seems to be sort of a new and popular kind of new and whatever, a new benefit that seems to be emerging in some of these MA plans. So that'll be really interesting to watch over time. And hopefully we'll be able to get some more data on what it all actually means, again, as another way to sort of test the waters.
And I'd love to jump in on this as well. Just the SCAN Foundation has been tracking a lot of the Medicare Advantage supplemental benefit flexibilities since the passage of the BBA. And uh, Tamara is absolutely right. We don't have a lot of data in terms of their impact, but we do have some data in terms of level of adoption among health plans of different kinds of benefits, and we have some interview and sort of qualitative data done with enrollees in terms of their experience with some of these benefits. And one of the things we observed, I mean, I think when these flexibilities first became available, I think there was hope for many that this could be, a meaningful way to address gaps in long-term care. I think what we observed, though, over time was, plans wanted to start offering these benefits, but quickly realized that they're incredibly expensive because people are expensive, and the workforce is an expensive component. And we've seen a significant sort of shift from offering some of these more concrete and tangible benefits to things like flex cards, or like allowances for individuals to use on select services. And so we've observed that the MA market is moving away from the LTSS specific types of benefits for economic and other reasons. And then on the enrollee side, cover it Medicare fee for service, MA, it's already incredibly complex for people to navigate. And so even if people are in some of these plans that offer these benefits, whether or not they're aware that they exist, whether or not they are eligible for them, varies significantly. So it just creates a lot more confusion, and to me really enforces the need for something bigger than a reliance on that Medicare Advantage program.
Good point. I just want to bring up David Stevenson in the chat brought up hospice as another piece of Medicare benefit that is sometimes sort of provides personal care. And so just want to note that, though I do want to move on to state initiatives. Okay, so regarding state initiatives, I specifically want to actually start with legislative approaches that we've learned from in the past. And so, Richard, this is a question for you about the Class Act. So, the Class Act was seen as one potential, it was actually a federal legislative action. I believe that if I have the dates right, I said previously you were at ASPE, but prior to that, you were the Director of Disability Aging and Long-Term Care policy at ASPE. At the time, the Class Act was both enacted through the Affordable Care Act and then repealed and officially dropped later. I wanted to know if you could talk us through a little bit about the Class Act, what the program was, and then what happened to it as a starting place.
It's not everybody who in their career gets to work very hard on putting a new benefit in place and then have it thrown out and repealed. So it's an odd distinction to carry. Anyway, so the Class Act originated with Senator Ted Kennedy, a different Kennedy from what we have today. And it was part of the Affordable Care Act. And I'll just give you the sort of very basic key elements of it. First of all, it was voluntary. Second, there was no outside federal subsidy. There were some subsidies for segments of the population, but it was all done internally to the premium system. It was a premium funded program. There was no underwriting permitted. And the benefit was somewhere, depending on the version, was somewhere between $50 and $75 a day for people that qualified based on the functional impairment triggers in the HIPAA legislation. They had all the problems that I mentioned earlier in terms of private insurance, but they did not have any of the tools that private insurance uses to limit the adverse selection types of problems. And so the program was in trouble from the beginning, which is when I came on board. So the challenge is to try to find ways to sort of retain some of the core principles. That is, broad access, not a lot of federal funding, but figuring out ways to mitigate adverse selection. And one other element that I forgot to mention was it was a cash benefit. And so the $50 a day was not a payment for a service. It was just, essentially given to the qualifying person to spend as they like. And that could have been used for hiring an aide on their own. It could have been used for buying home health services or even home modifications if necessary. So as the ACA moved towards enactment, there was a House version, a Senate version of the Affordable Care Act, but also of the Class Act. And there was going to be a conference committee because both houses had passed things. And as part of that conference committee, many of the issues around adverse selection, around the way the premiums were going to work, the level of benefit, how exactly the cash benefit was going to work, what the governance was going to be on all that, had largely been worked out. And then we had the election in Massachusetts, which meant that the Senate Democrats lost 60 votes. And so at the end of the day, it was the Senate version that passed, which meant that the Class Act did not have any of the fixes that had been worked on for the conference committee. And so it faced a variety of issues around adverse selection and other sort of challenges. And in the end, there continued to be work done to try to find ways to attenuate some of those problems, but there just weren't enough authorities in the legislation to sort of permit that within the statute. And so at the end of the day, Secretary Sebelius decided it really wasn't financially viable. And so she, as is stated in the legislation, had to make the call, and she made the call that it wasn't going to be implementable. And so, in fact, the repeal was sort of a long time after that sort of politically attractive coup de grace that didn't really mean anything.
Yeah. And were there lessons learned from this that have been helpful in more recent iterations, which have been at the state level of attempts to pay for long-term care?
Yeah, going back to the point Narda made earlier, Washington State has really, in a sense, uh, taken some pages out of the what would have been the Class Act playbook, which is they made their system mandatory, uh, where it has a mix of public and private kind of delivery system, and much like the Class Act, it's a very limited benefit. It's a $36,000 cap. Uh, and so the idea was you do something to just lighten the load. You don't eliminate the load. And it also created a set of tools that regulators and state officials could use if, in fact, this proves to be viable and successful to sort of grow the program in the future. Now, one of the consequences of that has been there were various exceptions in the law, and one of them was that if you held long-term care insurance, you were exempt from having to pay the tax. And so what that did is it created a new cottage industry on what I would call minimal long-term care insurance plans, which meant that they would offer a plan that was cheaper than the tax payment would be. And just to give you an idea, it's 0.58%. And so if somebody who makes $100,000 would pay $580. Okay, so not too bad for somebody. So it's not a huge burden, and therefore that's why it's only a $36,000 benefit. But you can imagine the types of policies that were being sold to make it a lot cheaper than that $580. And so what happened is there's this in the Affordable Care we refer to things called skinny plans. These are really skinny plans, and so they've been trying to close those loopholes, while at the same time there's been a legislative effort to actually make the program voluntary instead of. And so far, they seem to be closing some of the loopholes and making it continuing it as a mandatory program. So, in fact, we will see how it works out. But it's I think it demonstrates just how difficult this is, not only to kind of make work from a sort of policy side, but also how incredibly difficult it is politically.
Yeah, and I just want to piggyback off that, Richard, and go back to our competing quotes that we discussed earlier. In that, what we've also heard from the folks that were on the ground in Washington doing this work is it took years of sustained message development, talking with different stakeholder communities about both the pain points that they're feeling right now and how a program like this would alleviate some of those pain points. And so I just want to acknowledge, to Richard's point about we can't wait for the political window, but we do have to create the crisis, right? So I think what Washington did well in this instance is they helped people see the crisis that was before them to be able to get some of that political buy-in.
Yeah, and I will just add a little anecdote, which my son, who's in his 20s, lives in Washington State. And when there was a statewide vote about whether to make it voluntary, he called me up and was like, "Now, why do I need to vote to make this mandatory? I'm like in my 20s, and you want me to like have my payroll reduced?" So I tried my best to explain it to him. But there's a lot of people who I think, as we've said previously, this is a future problem that most people don't want to deal with right now. Okay. We are getting close on time. I want to just address one quick additional issue before we wrap up, which is the workforce. And so there's actually a question in the chat about, if we were successful in expanding long-term care payment and financing, do we have the workforce to support it? And I think research suggests at the moment no. And there's a lot of reasons that the workforce has been uh, sort of has suffered shortages, particularly since the COVID pandemic. I know, Narda, when you were on the Hill, you did some work around this. Maybe you could start out by just telling us a little bit about the challenges we're facing there.
Sure. And admittedly, my time on the Hill was before some of the recent, policy changes, which have had, obviously significant impacts on things like immigration, et cetera. But again, this is just an area that is politically quite prickly. And I do think it's really important that when we're talking about workforce policy change, that we are also talking about the benefits in terms of how it impacts the people, how it impacts family caregivers. Again, that sort of unified coalition is really critically important to be able to advance things forward. And there's also in addition to aging, disability, and labor, there is also industry, and when it comes to the workforce piece of this as well, right? And so getting buy-in among all four of those different constituencies is really challenging. So it takes a lot of some of that, wrestling ahead of time to get to a place of consensus to move forward.
I jump in?
Tomorrow. Oh, either one.
Yeah. Um, yeah, I think that as Narda alluded to, uh, you will not be able to solve this problem without dealing with immigration. And I think if you look at the existing workforce, we are very reliant on immigration. If you look at the future, given our birth rates and the nature of our labor markets, I think it's unimaginable to address the workforce issues without immigration policy. And along with that comes the Social Security, which is the sort of same population that you will not be able to finance Social Security either without immigration reform. So I think that it's, if there's one thing you wanted to do on workforce, I think it would be do something about immigration that will help get more skilled people in to that work.
And I agree with all of that. I agree that workforce can be very prickly politically, but at the same time, I'm always struck by the fact that the need for more people in the workforce, the need for nursing homes to have more staff, for example, is the one thing that all sides agree on, right? Providers acknowledge this, advocates know this, consumers know this, and obviously the workforce itself knows this. Everybody agrees that sort of the key to better long-term care is, and probably also to access, is workforce. It's just such a fundamentally important issue. And to me, it really comes back to the financing, right? And this uh, larger challenge of how we finance long-term care and the gaps that there are. This dominance of Medicaid, where state budgets are constantly being squeezed, means that, I know there's lots of arguments about whether or not payment rates are actually sufficient for nursing homes to, there are lots of good arguments on both sides about whether Medicaid payment is actually sufficient to provide um, high quality care in nursing homes, or at least a sufficient standard of care in nursing homes. But if we really want to improve the workforce and improve the ability of long-term care providers or organizations to attract and maintain a workforce, it really comes back to resources, right? Because everybody agrees staffing is important, but where nobody agrees is how to pay for it, right? And I think that a continued reliance on Medicaid with all of the other pressures it's facing is never going to get us to where we need to be in terms of hiring and retaining enough staff to provide this service.
Yes. Okay. Well, we have 5 minutes left. I want to end with a more forward-looking question. I mean, this has been a great discussion, so thank you all for that. But I wondered if we could just do a round robin, and each of you could share both a short-term recommendation and a long-term recommendation that are at the top of your lists for fixing or addressing long-term care financing in this country. And so you each have, like a minute and a half-ish. And who wants to go first?
I can start if I don't know. Everybody just unmuted, so I
You're
don't
good. Go ahead.
know. Um, yeah, I like to think about this in short-term and long-term ways. To me, the best short-term solution is what I described earlier, which is to really focus on expanding the Medicare home care benefit. It feels very incremental. It's actually not that easy because it still takes action by Congress. But it feels very incremental and something that we could actually accomplish if people see the benefit from all Medicare beneficiaries having access to meet some of those unmet needs. In the long term, I feel like everything we do, everything that's been tried, is really incremental, is not going to change or really solve the broader challenge. And so I think in the long term, we really need more fundamental structural change. And uh, politics aside, I think to me, the best solution would be to expand Medicare, to have the responsibility for long-term care move out of state budgets where we see that there are a lot of inequities across states. And, there's constant pressure on Medicaid rates for long-term care. And if we move that into Medicare, it would solve this issue of the middle class really not having any source of financing for long-term care. So it would even out that benefit and not leave these groups with no options. It would also be a vehicle to sort of smooth choices between home and community-based services and institutional care. Um, I think it would have to be some kind of public-private partnership, right? It wouldn't have to be completely taxpayer funded, but I think it would be hard to do without some subsidies. But that to me is the real long run solution that I hope we could eventually get to.
Thanks.
I'm happy to go next. So I think in all of this, I think the biggest factor for me is not creating further factions between the aging, disability, and labor communities. And so from a near-term perspective, there's been some work, for example, in Wisconsin in terms of providing stipends to near eligible older adults and people with disabilities to be able to decide on their own how they want to be able to um, finance, their long-term care. Obviously, it's a very incremental and nominal amount and step, but I think potentially could give us some additional information in terms of what people find valuable and what they don't. To Richard's point about the full loaf versus, a couple of slices, you know, rather than, and then I think that can help inform the long-term vision, which, for me, I, would hope for a more universal social insurance program. But that is really informed by what people need and want, as opposed to, what people inside the Beltway assume people need and want, so that we can ensure that that program is designed in a way that is maximizing efficiency and getting people what they actually need and want to be able to stay in their homes and communities.
My thinking is kind of along the lines of Tamara's as well. I think that one of the big challenges, given our reliance on Medicaid today, is that home and community-based services are not an entitlement, and that creates a lot of mischief. And I think that edging towards that, and I think that's very difficult to do it in the existing Medicaid structure. And so I think that moving towards a Medicare home benefit, that would be, separate from the home health care benefit to some extent, and financially structured quite differently. I think would be a good step in that direction, and that's not just an incremental step, that's a pretty big step. But at the same time, I think that because there would be a dramatic change in the responsibilities of state government, I think there could be some opportunities to change the way we do institutional care with some of the additional funds. And I think that my long run thing is that, I think we really need to, in the wake of COVID, rethink the whole nursing home thing. Because on one hand, nobody wants to go there. And on the other hand, I think we're going to need it for a segment of the population, particularly because of the growing numbers of people with dementia and the shrinking family sizes in this country. And so I think we're going to have very little choice other than to find alternate institutions that serve some of the functions of nursing homes, but are kind of different, but that will continue to provide that complete array of protections and supports.
Great. I have a lot of questions, but maybe we'll do that next time. Thank you so much for joining us, all of you. It's been a great conversation. And thanks to the audience as well. We have another event coming up in January, part of our Decoding the Moment virtual event series, which is a collaboration with Trade-Offs, where we seek to provide timely and evidence-based discussions on federal policy changes of the moment. And so our next Decoding the Moment will be on the Rural Health Transformation Program. It will take place on January 6th on Zoom, and we hope to see you there. Thank you all for joining us, and happy holidays.